Okay, perfect. Good morning, everybody. My name is Diana. Thank you so much for coming to our presentation this morning. I know Saturday isn't the most ideal day, but it's greatly appreciated that everyone is here. Um, so let's get started. As Sandra mentioned, we are with UCI, the University of California, Irvine. And yeah, so I welcome. Like I said, my name is Diana. I am one of the clinical research coordinators at UCI. I'm one of the coordinators for various studies here at UCI. I'm also the outreach and education coordinator, as well as somebody who provides resources, and I will be the moderator of today's event. If you have any questions related to research or a little bit about what I do, or if you're just in the need of some resources, my contact information is at the bottom. So I don't know if anyone is going to take pictures or note that down, but of course, at the end of the presentation, if you would like for me to come back to the slide to see you could annotate or jot down the information, please let me know. I will be moderating the chat the entire time. And now I'm going to pass it on over to our three wonderful specialists that we have here today who work with us in these studies as well. So we can start with Dr. Hom.
Hello, I'm Christy Hom, and I am a pediatric neuropsychologist. I'm involved in multiple studies here at UCI as the principal investigator, and we are studying aging and Alzheimer's disease in people with Down syndrome. And we've also had a study that looks at children and adolescents with Down syndrome and some of their health conditions and biomarkers for Alzheimer's disease that may start prior to adulthood. And I'm happy to be here. And next, we'll have Dr. Dow introduce herself.
Good morning, everyone. My name is Dr. Emily Dow. I've been at UCI 24 years, and I've been seeing adults with Down syndrome for the past number of years, about almost 10 years, in fact. I am definitely interested in transitioning pediatric patients to adult care because I know that's an issue. I love seeing my Down syndrome patients in my clinic. Dr. Totoyu?
Good morning, everyone. My name is Minodora Totoyu. I'm a pediatric neurologist. I'm working at Children's Hospital of Orange County, and also part of my job is working on the clinical research ongoing at UCI. So I'm part of the same research studies that Dr. Hom mentioned about. In the clinic, I'm seeing a lot of children with Down syndrome and making sure that they achieve their maximum health and developmental potential. Luckily, we have Dr. Dow where I can transition them when they outgrow our pediatric clinic. I'm happy to be here today and present about the conditions that children may have, and happy to answer your questions after.
Awesome, thank you. So now we're going to move on. Just a little overview about Down syndrome. So as some may know, Down syndrome is one of the most common chromosomal causes of intellectual disabilities. Advances in medicine, advances and research, I may say, have allowed people with Down syndrome to live much longer lives. And the knowledge and management of these issues at an early age can make a big difference in long-term results. And yeah, we can move on. I do believe Dr. Totoyu is up first.
All right. So children with Down syndrome are like any other child. They have the same diseases, but some of them can have them more frequently. And these are some of the diseases that they can have more often, such as hearing loss, ear infections, and those sometimes are due to the fact that they have narrow ear canals, sometimes clogged with wax. They are more prone to infections. They can have vision problems as well. Most of them need glasses, but they do not like to wear them, unfortunately. You need to work on convincing them that they look cute with the glasses and they need them. About 40% of children with Down syndrome are born with congenital heart defects. And luckily these days, those can all be repaired and they can have a normal life after that. Many of them develop hypothyroidism or autoimmune thyroiditis, which is also very treatable. It just needs to be detected on time. And because of that, we check their thyroid function on a yearly basis. About 15% of children with Down syndrome have co-occurring autism. At CHOC, we have, at the Children's Hospital Orange County, we have also the Thompson Autism Center, where we see the children in a co-occurring clinic with a developmental neurologist or developmental pediatrician. And in the meantime, we address their medical health as well as their behavioral health. Some of the children can have seizures, and the most common type is infantile spasms, which is a variant of seizures that it's very treatable in children with Down syndrome. Just need to be detected in time because there is a window of opportunity, about 4 to 6 weeks, to treat them. They have more often celiac disease, about 6 times as many as often than other children. And returning back, they have also more frequently sleep apnea, which can be due to the fact that their muscles are hypotonic. Their tongues are bigger, their tonsils are bigger, but that's also can be addressed by the ENT doctors and the sleep physicians. And not the last, they can have also leukemia. About 1% of children with Down syndrome develop leukemia, is very treatable. And they can have also orthopedic issues. One of them is the neck instability, which is called atlantoaxial instability. And they have to have like an X-ray of their neck before starting to play sports to make sure that they do not have that atlantoaxial instability, because it could prone them to have spinal cord injury. And some of them have hip dislocation, again, due to their hypotonia. You can advance to the next slide. Also, as you probably all know, their development, it's much slower compared to other children. They have delays in reaching their developmental motor milestones. They need more time to learn these skills and need therapies, need help, need more practice to achieve those, but they are very able to do it. Their language also develops slower. They can say their first words when they are 2 years, 3 years, 4 years old, when by age 2, typical children can speak in 2-word phrases. So they would benefit from intensive language therapy that can be started around 2 years of age and continued as long as possible, because even if they are adults, speech therapy can help. And lately, they develop their activities of daily living skills much slower. They need more help to learn to feed themselves. They need more help to toilet train them. And those are typically achieved at later times. As far as socialization, they are very friendly and they enjoy to meet new people, interact with new people. They like music, they like to dance. You can advance to the next slide. Because of all those conditions that they have, it's very important to pay attention to their nutrition and activity to maintain proper weight. So during the early childhood, they have difficulty feeding, and they are smaller, but as they grow, when they are teens, they tend to eat more and become less active, and because of that, they tend to gain weight. Very important during teenagers to be involved in many activities and keep them moving so you prevent that weight gain. Because of the fact that they are hypotonic, they move slower, they have less self-protective mechanisms, and they are more prone to injuries and abuse. So you really need to protect them. To cover all their medical needs, these children and adults would benefit from participating in a family-centered medical home, and to have the support from the programs that they are available, which are the regional center, medical, through the school system, the individual education plan, and also for those children who have more extensive medical needs, the in-home supportive services, or IHSS. Can go to the next slide. In order to support development and growth of children with Down syndrome and to achieve their maximum potential, for parents, it's very important also to learn as much as possible about Down syndrome. This can be done through reading, to participating to this kind of activities. Also, there are educational materials that can be accessed from different websites. And it's very important to give your children daily tasks and responsibilities and to challenge them because they are able to learn. I think the most detrimental is that parents would do everything for them when they are little, because that will hinder their development. Also, it's very important to learn about what your child is learning at school and at the therapy places, and if you have the option and availability to practice those skills at home. Look for social opportunities in the community, like the DSALA. Talk to other parents of individuals with Down syndrome, and please be patient with them and teach them skills. We can go to the next slide. It's very important to read to them, to talk to them, to play with your child as you would play with other children. Provide them as many opportunities as possible to help develop their life skills. Encourage them to do things for themselves, and make sure that they have positive experiences with new people, new places, new activities. And now I will have Dr. Dow talk to you about adulthood.
Thank you, Dr. Tatoyu. Next slide, please. So the transition from pediatric care to adult care can be quite challenging. And I really encourage all parents and caregivers to start planning early. Some of the pediatricians continue to see them until age 18 or 21, for example. So before the children reach either age, start planning and see whether there's somebody, a primary care physician, that can transition the care from pediatric to adult. And everybody should have a primary care physician. And that could be a family physician like me, could be an internal medicine physician, an internist, or somebody like somebody who specialized in both internal medicine and pediatrics, and we call them med-peds. But everyone should have a primary care physician. Just as you have a pediatrician for the children, and I know that during childhood, your child may have a GI, a gastroenterologist, an endocrinologist, an orthopedist, or something like that. So keep in mind, primary care physicians, we are trained to be like a one-stop shop. So we take care of endocrine problems, thyroid problems, for example. We take care of constipation. So that might be new. We take care of a lot of acid reflux and so on. So as the Down syndrome individual becomes an adult, they may need more specialist care or fewer. In most cases, fewer, because primary care physicians are able to take care of most primary care needs. As Dr. Totoyo mentioned, people with Down syndrome are prone to the same diseases and health problems as adults without Down syndrome, but certain conditions occur more frequently and at younger ages. Next slide. For example, sensory loss. People can develop early cataracts. Most adults without Down syndrome develop cataracts in their 40s, 50s, 60s. Usually they present in their 60s, but Down syndrome individuals may develop early cataracts, like in their 20s, for example, or even 30s. There's a condition called keratoconus that we need to be on the lookout for. And this is cone-shaped cornea that interferes with their vision. That's why most people need to be seen by ophthalmology every 1 to 2 years. Now, hearing, you may have children who develop early hearing loss, so that continues into adulthood. Now, a very common condition is earwax buildup. So usually I check their ear canals every time they come in to see whether there's earwax that's built up. Their ear canals tend to be smaller. That's why earwax is normal in everyone, but they have a hard time getting the earwax out. Sometimes, if the patients are cooperative, we can try to remove the earwax in clinic, in the exam room, using warm water and hydrogen peroxide. But many people need to be referred to an ear, nose, throat doctor just for the earwax removal. For gastrointestinal problems, lots of acid reflux we see, some celiac disease as well, about 15%, 5 to 15% may present with celiac disease, which is with anemia, chronic diarrhea, for example. And we test, it can be a blood test, and then it might even involve endoscopy to diagnose somebody with celiac disease. Musculoskeletal problems, arthritis, usually osteoarthritis that we see in most people after the age of 50. In people without Down syndrome, we may see this condition earlier, affecting their spine and joints. Now, osteoporosis is different. It's just lower bone density that tends to cause fractures. With small falls, they can have fractures. That's different from osteoarthritis. This doesn't cause pain. It just causes fractures. That may happen earlier as well. Next slide. Endocrine, we mentioned hypothyroidism. We can see up to 50% of patients with thyroid that's not functioning. We also have hyperthyroid, where the thyroid is functioning too much. This affects their metabolic rate, but it's hypothyroidism that's much more common in Down syndrome individuals. I manage all my hypothyroid patients, unless the parents prefer that an endocrine specialist sees them because they've been followed by endocrine all along. It's a matter of checking their labs once a year and adjusting their medication. Now, many people think that Down syndrome individuals need to be on the brand Synthroid. That's not true. Levothyroxine is the generic thyroid medication that I use in nearly 99% of my patients. The only problem is that small changes in the doses can affect the thyroid, the way in which they react. So we need to be very sensitive and very careful in adjusting the doses. People can have high cholesterol. We manage cholesterol problems. We don't start cholesterol medications until age 40, for example. There's no evidence that starting medication earlier is beneficial, although I do have patients with Down syndrome patients with very elevated triglycerides, which is fatty acid or fat in the bloodstream, in which case we have them on multiple medications, including a cholesterol-lowering medication, like a statin, for example. Diabetes is actually uncommon, thank goodness, in Down syndrome adults, but we do see that from time to time. Obesity, very common, up to about almost 40% have obesity and about 35% overweight. This is a big problem, as Dr. Totoyo mentioned, and this is something that we need to address at each clinic visit to make sure people are following a balanced diet and getting exercise, regular exercise every day. Dr. Totoyo mentioned congenital heart disease. Many times when they come to me, they're already under care of cardiology, or many of the patients have already had heart valve repairs and so on. Now, the only problem is that sometimes they can present with new heart valve problems as adults. They can also have irregular heart rate, but we can also refer our patients to adult cardiologists. Dental problems is a big, very important issue. They can present with gum disease, gingivitis, periodontal disease. They can present with cavities or tooth loss. Now, with some of the Down syndrome patients, they have a hard time cooperating with the dental exam. Sometimes we may have to have them undergo dental exam under general anesthesia. And I work with a dentist who also happens to be an anesthesiologist, so that when many of our patients are not able to cooperate with lab draws, for example, we do the lab draws at the same time as the dental exam. And so that has worked out very well. And hopefully you all have a dentist that you can trust to be very gentle with the Down syndrome individuals, and at times having to use dental to undergo dental exams under general anesthesia. Next slide, please. Sleep disorders. Sleep apnea is very, very common, and it's not always associated with obese individuals. Just this week, in fact, I diagnosed somebody with sleep apnea, mild sleep apnea, and her BMI is low, in fact. And this sleep apnea can cause functional and behavioral changes because they're not able to get that air in their airway as they sleep. And using CPAP can be very, very challenging. Many of our patients are not able to tolerate CPAP. There are some websites with videos, YouTube videos, that you can watch along with your children to see whether you can get them used to using the CPAP. It doesn't have to be a mask. Masks are better than just the nasal cannulas, but there are different ways, different options, and maybe get them using the CPAP machine during the day, watching TV for an hour at a time, half an hour, then an hour. Ideally, people use it for at least 4 hours per night. I know it's not always possible, but we need to be working with our sleep medicine specialists on this because it can really improve the quality of their lives. In terms of neurological issues, they can present with adult onset seizures when they hadn't had seizures as children. Next slide. Down syndrome regression disorder. This is a rare disorder that I'm actually seeing in a few patients that I've referred to CHLA, the team with Dr. Jonathan Santoro. This usually occurs between the ages of 15 to 30. I have a patient who's in his 30s who has this, and they present with sudden loss of skills, cognitive skills, memory issues, for example, language issues, refusing to speak. Their speech all of a sudden becomes limited. Personal and self-care skills, ability to take care of themselves, what they were able to do previously, they're not able to do. Social skills, they prefer to be alone and not interacting with other people, for example. Sometimes we see them with extreme slowing of movement or catatonia, whether they look like they're stuck in one position. They're slumped down. They're not meeting your eyes. They have poor eye contact. I have a patient who's stuck in a position with the arms raised like this, looking at something that nobody can see. I don't know whether they're having hallucinations, for example. A direct cause has not been identified, but there's ongoing research at Children's Hospital of Los Angeles. Now, this is different from Alzheimer's disease, and we can talk about that. We'll talk about that. Next slide, please. Early onset Alzheimer's dementia is something that we see. It's extremely rare in people younger than 40. So you might think, maybe there's some confusion between Down syndrome regression disorder and Alzheimer's disease, but it is extremely rare to see somebody with Alzheimer's disease before the age of 40. About 25% of people present during their 40s, not at 40. I think we may need to change this slide a little bit. I've missed this one. During their 40s, 25% of people present. 50% of people present during their 50s. 75% during their 60s. There is an increased risk of Alzheimer's disease, but some adults do not develop Alzheimer's dementia during their lifetime. Not everybody gets Alzheimer's disease. And doctors and scientists at UCI are working to understand and treat Alzheimer's disease in people with Down syndrome. For example, Dr. Hom and Totoyu. Next slide. So how do Alzheimer's dementia present? There are changes in memory, changes in behavior and personality. There's slowness. So these are somewhat similar to regression disorder, Down syndrome regression disorder. This disorientation in time and place, unable to recognize familiar places and people, sleep problems, disruption in their sleep routine, changes in appetite, incontinence of stool or urine, and they're less functional in daily activities. Again, loss of their daily living skills and loss of interest in hobbies. Next slide. So planning for the future, many people understand more than you think. Many Down syndrome individuals are able to understand more than you give them credit for, in fact. So please include them in all life decisions. And it's not uncommon, as you know, for people with Down syndrome to outlive their parents. So we need to be planning ahead. We need to think about group homes and independent living opportunities. Some of my patients actually live on their own with some caregivers looking in on them. Many of them live in group homes because they need very structured routines. Some of them even work. There are employment opportunities and even retirement from employment. So we need to be planning for long-term financial issues. Conservatorship is when the individual themselves are not able to make decisions for themselves, and then the parents or somebody that the family names becomes that conservator, makes the decision completely for that person. Or power of attorney. Power of attorney is different from conservatorship in that the Down syndrome individual names a person to be their power of attorney. I have some very high functioning Down syndrome patients who say, I would like my mom, my dad to make decisions for me. So that's power of attorney, whereas conservator just makes the decision for them from the get-go. The maintenance of cognitive and social activities, keeping them stimulated and having them in social activities every day so that they're not alone and left to their own devices for hours at a time is not recommended. They need to be social. As Dr. Totoyu said, they love music. They love to dance. I haven't met any Down syndrome individual who doesn't like to dance. So they need to be involved in social activities. Next slide, please. And that is Dr. Hom's arena.
All right. Good morning, everyone. So I'm going to talk more about common behavioral issues seen in children and adults with Down syndrome. Next slide. The most common ones in childhood is difficulty and slowness in learning. Another common concern that parents have reported is that they may be stubborn and resistant and defiant. Some, not the majority, but there are some who can also be aggressive towards others and some towards themselves. So they'll engage in some self-injury. Attention problems as well as impulsivity can also be a problem. These, it could be to a level that there's an additional diagnosis for ADHD, but there's also difficulty with attention that is understandable given their cognitive limitations. So they're not going to be able to understand as much. And so they were not going to be able to pay attention to a TV show or a conversation for as long as somebody else their age. And because of some of that limited understanding, they may also have poor safety awareness and, engage in or do things without thinking through the consequences. And so impulsivity can become a safety concern. They also have more difficulty regulating emotions, such as anxiety, frustration, anger, and depression. That would be later on, more in adolescence than in childhood. A small proportion of individuals with Down syndrome will also have co-occurring autism. So they will have the same features of being fixated on a limited number of interests, engage in repetitive body movements, have difficulty, even more difficulty than other people with Down syndrome, communicating, and really have that insistence on sameness. Things have to be done exactly in the same order, in the same way, every day at this time I have to eat. I had one every day at 3 o'clock, they had to eat a pretzel. So there are some things where that are more attributed to autism than Down syndrome per se. All of these different types of behavior problems are going to limit their ability to interact with their peers in age-appropriate ways or to possibly attend community-type activities. They can increase caregiver stress, and it also may limit the development of many important independent living and work skills. So it's important to get these treated as soon as possible. Rather than thinking that they'll just outgrow these things, that as they get older and more mature, these problems will go away. That may happen in some cases, but for the majority of cases, you need to actively develop a treatment plan to intervene. Next slide. In adulthood, that resistance and defiance can continue, and it's also much harder to physically assist or move an adult versus a 5-year-old child if they're not willing to, go along with whatever that day's programs are. So dealing with the resistance in adulthood, it becomes often much more difficult than resistance in a child. Other problems are withdrawal, lack of motivation, depression, anxiety. We used to have a clinic that was sponsored by the Regional Center of Orange County. So we saw lots of people with Down syndrome in that transitional age from finishing schooling, so more around that age 22 and into young adulthood. And it was very common for them to start feeling depressed around that age. They've lost their social support. They've lost what's familiar to them, going to school 5 days a week, having teachers, classmates, all that cognitive stimulation and social stimulation. And then in adulthood, they don't have as much of that planned programming. They're also watching other people, including their siblings, become adults, getting married, driving a car, getting a job, moving out of the house, and they see that they're being left behind or unable to do those things. Other problems in adulthood are changes in mood. They can develop, a lot of irritability and agitation. There's also physical restlessness, and some have aggressive behaviors. Next slide. So there may be different reasons for these challenging behaviors, and there can be different reasons for the same type of challenging behavior. It's really important to try to identify what might be causing it or triggering it. Stressful life events, history of trauma or abuse are certainly the most well-known causes, but also inconsistent rules and expectations between people in their life. So if they go between households, maybe mother's rules are different than father's rules, or even between the day program and their household. There's also difficulties with communication, and we know that there's a direct correlation. The more limited the communication skills, the greater the likelihood of having behavioral issues. And that's probably not hard to understand, because if they can't communicate effectively what they want or how they feel, and other people don't pay attention, then if you get mad or throw something, that's an easier way to get people's attention. Limitations in their coordination and physical strength can also lead to some of these behaviors, especially like the resistance or low motivation in exercising or attending programs that or activities that may require more stamina. Sleep disorders, we've already talked extensively about how common they are, and they are known to affect daytime mood, attention, and behaviors. As Dr. Dow had mentioned, because of that narrower pathway, less oxygen is getting to the brain throughout the night while they're sleeping. And all of our brain cells need oxygen to maintain normal function, to be healthy, to resist damage and toxicity, and also to improve the communication between brain cells. So when they are getting consistently less oxygen to the brain during the sleep hours, that can lead to all kinds of functional problems. GI problems and pain are also common reasons for challenging behaviors. So it's also important to recognize that, and if that's the case, if possible, to treat that, as well as seizures. Next slide. So there are many different things you can do to reduce or manage or to retrain people with children or adults with Down syndrome in improving their use of appropriate behaviors. One is to improve their ability to communicate, whether it's using sign language, certain code words, some kind of picture exchange, or any type of thing where it's helping people around them to understand what it is this person wants or needs or their discomfort. Also improving the quality and duration of sleep, as we just talked about. And it's also really important to identify the reason for certain problem behaviors, especially behaviors that occur pretty regularly. The most common reasons is to get something. So if you want something and the family member or caregiver says no, you might go get it anyways. You might sneak around them. You might, push them or be a little bit physical to do that. Or you might just throw a tantrum. If it's something you can't physically get and you throw a tantrum, and that person, the other person doesn't have the time or feels distress, they might give in and give them what it is that they want or buy something that they want. Another common reason is to avoid something that they don't like to do. And it could be schoolwork, it could be going to bed, it could be taking a shower. If they're throwing a tantrum or just creating a lot of resistance, then the person who's asking them to do something might just give up or clean up after them instead of forcing them to do that. Another common reason for problematic behaviors is to get attention. And this is something that may be a little bit hard for some people to understand. People with Down syndrome like that socialization. And so even negative attention can be reinforcing. So it's not just when they get praise and when they receive compliments from people, even when the teacher or a parent is saying to them, stop doing that, don't do that, or, you need to do this, or they're dropping whatever they're doing, whatever conversation they're having, or whatever they're in the middle of, to go pay attention to the individual who is misbehaving. That is still a form of attention, and that can still be reinforcing or rewarding and leading to future likelihood of engaging in these kinds of behaviors. And then there's also reasons where it just feels good to them or it's pleasurable. So overeating, they like to eat. So you can understand, we've all been there where we just derive pleasure from doing certain activities. But for the person with Down syndrome, they may not understand the need to stop or when to stop. So it's important to set clear expectations and to be consistent with the consequences. And this is not just unique to parents of individuals with Down syndrome. This is applicable to all parents. Having unclear expectations. And sometimes that's being too broad or too vague. When you say, be good, behave, listen to the teacher, that's a really broad expectation that may be hard for the person to understand or to know which one is part of the listening and which is some other category. Or when they say be good or be nice, again, what constitutes nice? When you say something to be more specific, like if somebody talks to you, answer back. When somebody talks to you, make eye contact. Or when you don't want to do something, use your words. Those are clear expectations rather than this general type of statement of, make good choices. Those are terms that I frequently hear parents say that, we tell them they need to make good choices. But if they don't know what their choices are, they don't know which one's the better choice to make. And then also it's important to increase your expectation for good behaviors and to provide positive reinforcement for what it is that they do. So one thing people tend to forget is that if they are doing what you want them to do, you should recognize that. And that's going to lead to more likelihood of them doing that thing again. Instead, what happens sometimes is parents don't pay attention until the child meaning, pediatric or even an adult child is not doing something appropriate when they are engaging in something inappropriate or yelling or throwing a tantrum. That's when they get that attention. And so it's become reversed where they're not getting recognized for the good things that they do, only for the bad things. Next slide. So, whilst many of these behaviors can be common to Down syndrome, it's also important to know when it's important to seek help and get professional help and treatment. That can be in the form of medication to manage some of these behaviors. It could be in the form of therapy, psychotherapy, or behavioral therapy. A lot of it depends on the type of behavior and, again, the underlying cause for that behavior. But any kind of serious self-harm, hitting the head or body, biting themselves, anything that's really like breaking the skin a lot, all those, can lead to infection or serious injury. Physical aggression towards others. Any major change in mood or personality is also concerning. And so you want to intervene early, especially if it's not clear what's leading to that. For example, if a person has changed schools or changed group homes, or there's new staff, that it may be more understandable, and that may be just a temporary thing. Anyone who has significant anxiety or fears that interfere with their daily activities. So things like fear of getting sick or safety. So they are refusing to go places, or they're spending excessive amounts of time washing their hands, taking a shower. This is interfering with their ability to do their typical activities, or things that are, again, interfering with him going to school, and there's suddenly this significant separation anxiety, and morning drop-off is almost impossible and requires multiple adults to help assist. A lot of these things are very treatable and are not unique to Down syndrome. So there can be many providers who are able to provide assistance and treatment for this. Changes in cognition. This will probably apply more in adulthood than in childhood or adolescence, but any kind of changes in cognition, not being able to concentrate or remember things as much as they were before, certainly confusion, where they are, what they were in the middle of doing, and increased impulsivity is also unusual. Usually impulsivity decreases as people get older, so there shouldn't be an increase in impulsivity. And any significant changes in functional abilities also should be discussed with their primary care physician, at least at a minimum. Next slide. Okay. And so we like to end here, but we are like to also let everybody know that we have a lot of different clinical and research programs at University of California, Irvine. I know this is in Orange County, and many of you are in Los Angeles County, but we would be happy to provide you with resources. Some we have in print, and other times it may be more referrals that people are looking for. This is our general phone number and email address that you can use to contact us. Diana gave all of you her specific contact information, and you can always contact her as well. Next slide. Okay, now we'd like to open it up for questions, which, again, please type in the chat, and Diana will go through that and ask the panel.
We already got a few questions in the chat right now. Our first question was from Raquel. So she mentioned the audiologist has been unable to get a hearing test on her son. She recommends the audiologist recommends that he has an auditory evoked response test under sedation. She's just wondering, how does that test measure the hearing if the patient is asleep?
I can answer that question. So basically, they look at how the hearing nerves are working. There is an electrophysiology test. They don't need to determine exactly how the hearing is working. They determine how the hearing nerve is transmitting information. So it's a test that looks in a way similar how they do test the brain waves. They put some electrodes and they transmit a signal, and they measure how that signal is traveling through the hearing nerve. And then the audiologist can determine if that's a proper speed of the transmission of the information through the nerve. And that determines actually how the nervous system part of the hearing is functioning. And then the ENT doctor can look through the ear and determine if there is any middle ear fluid, or also this audiologist showing if there is any delay in transmission due to fluid in the ear. And then the ENT doctor determines of what the next step would be.
Great. Thank you so much, Dr. Tutoyu. I have another question from Sue. She is asking, should an adult have a colonoscopy?
I can take that question. So for colon cancer screening usually starts at age 45. There is no evidence that Down syndrome individuals need to start earlier. There's very little research on that. And so the usual colon cancer screening starts at age 45. Fortunately, Down syndrome individuals have lower risk of solid tumors, except for testicular tumors. So it would be rare, but I do recommend colon cancer screening starting at the age of 45. It used to be 50, now it's 45. And it doesn't have to be a colonoscopy, and people will be sedated. You can do a fecal immunochemical test. That would be an yearly annual exam. There's also colonography, colonoscopy, where you're sedated and a gastroenterologist performs that procedure in a suite. That is the gold standard. But if the individual is not able to cooperate, or if you have concerns, you can do annual fecal immunochemical testing. We call it FIT testing.
Great. Thank you, Dr. Dow. Now Susan asks, her daughter is 41. She's experiencing lots of hair loss over the last years, healthy diet, and monitored by their doctor frequently. And she's asking if you have any other suggestions.
So, one of the first things that we check in anybody who complains of hair loss is their thyroid function. And more often than not, their thyroid function is completely normal. Now, if it's been going on for years, you may want to consult a dermatologist, but it's usually temporary. There is this condition called telogen effluvium, whereas the hair follicles all grow at the same time. And sometimes, this happens during pregnancy. Sometimes if you're taking birth control pills, it can happen. Sometimes after a traumatic event, it can happen too. But I'm sure, your primary care physician has checked the thyroid function. Thyroid function should be checked every 1 to 2 years. And so that's the first thing that, of course, I would recommend.
Thank you, Dr. Dow. Now Melanie is asking, how can you tell if a teenager is just going through adolescence as opposed to developing regression syndrome? She sees her daughter regressing, not speaking, and forgetting things that she learned for over a year now. They have been evaluated by CHLA, and they don't seem to think it's regression yet. Any comments or?
Maybe if Melanie could elaborate more about what you say that she doesn't seem to be remembering. So motivation is a big factor, especially in adolescence. So I've heard parents say, oh, they're forgetting to do their chores or forgetting to clean up when they, use the table or some kind of activity. And it may not be that they're forgetting, they're just choosing not to do it. And that would be a motivation issue. not a true memory problem. But memory problems are rare, prior to the age of 40.
I might add, maybe thinking about whether the teen is depressed, for example, because depression can lead to memory impairment. Adolescence itself is a challenging time. And so you might, think about whether the teen is depressed or anxious.
Also, I would like to add that the diagnosis of regression in Down syndrome, it's doesn't really have a lot of testing to make the clear diagnosis. And because of that, there are some clinical criteria that they have to meet. And if she was already evaluated by the CHLA team, I'm pretty sure that most likely she doesn't meet those clinical criteria. So I would suggest to try to get a neuropsychological testing to determine, if possible, what's the real underlying problem of this symptoms.
Right. And let me also say that you can also see a psychologist too, and try to treat it behaviorally first to see if making some changes in expectation and consequences, or giving more preparation, advance notice for what she's expected to do, if that makes a difference.
By the way, I might add, there is a checklist for Down syndrome regression disorder in the National Down Syndrome Society website, if people have questions about Down syndrome regression disorder.
Perfect. Thank you, everybody. Tom now is asking, how do you know conclusively whether or not you should get a sleep study?
I can answer that for childhood. Usually per the guidelines of American Pediatric Academy, children with Down syndrome should get a sleep study by age 3 or 4 to make sure that they do not have it. And then, as based on symptoms, if they snore, if you hear that they have pauses in the breathing when they sleep, definitely they should get a sleep study regardless of age. Also, if they are tired during the day, cannot go by their usual routine, sleep apnea could be a reason, because their sleep is not refreshing, it's interrupted, they keep waking up, going back to sleep, and not being refreshed by the morning when they wake up. So any of these things could trigger a need for a sleep study.
For adults, definitely, as Dr. Totoyo was mentioning, snoring, episodes of pauses in their breathing while they're sleeping. Of course, that would lead you to talk to your primary care physician about getting a sleep study. Now, sometimes some of the patients don't snore, but there may be some changes in behavior. That's when you might consider a sleep study. It's a difficult question to answer for when is it definitive. Of course, snoring, apneic episodes, absolutely. But other times when they're not snoring, but there are changes in behavior, and it's not depression, anxiety, it is difficult. It is a consideration.
Great, thank you. I have another question from Melanie. She asked, have you seen absence seizures like activity and chorea, like movements with negative or intermediate EEGs and seizure medications?
I guess that's a question for me. And yes, as any other children with Down syndrome may have absence seizures, which has a very typical EEG pattern. If an EEG was done and they don't have that pattern typical for the absence seizures, they may have other kind of seizures that look similar, and those are the complex partial seizures. EEGs can determine, but sometimes they need a longer EEG, not just the typical 1 hour. It might need to be recorded overnight for 24, 48 hours, trying to capture those particular episodes. And if during those episodes the EEG doesn't show any changes, then you may consider that they are not seizures, but behavioral, like checking out. They don't pay attention. Sometimes they look like having an absence, they're not there, but in fact, they are just like daydreaming. And that can be determined with like a long-term EEG monitoring. Now, also regarding chorea-like movements, sometimes some seizures have particular type of movements that can look maybe choreiform. So again, the long-term EEG would be very helpful to capture and determine how the brain waves look like during those episodes. They can have also movement disorders like any other people. So it's important to see a neurologist and do the proper testing. And also, sometimes some of the seizures come from the deeper areas of the brain, and it's more difficult to capture from the scalp EEG. So that's an epileptologist that would be appropriate. If the EEG is indeterminate, definitely they need to look deeper into that. I hope this answers the questions.
Thank you, Dr. Shatoyu. Moving on to, I believe it's Julie. She's saying, if seeing anxiety that is interfering with life skills, would you recommend starting with a primary care doctor or going to a neurologist?
I would actually recommend seeing either a psychiatrist or a psychologist rather than. So primary care physicians, I'm not too sure about all of what their training
A lot of
is.
anxiety. We treat that. I can respond, but go ahead.
Okay, go ahead. I was going to say a lot of times I see they put them on a medication.
Right.
Quickly.
And in fact, I see a lot of patients with depression and anxiety. And, as a family physician, it's part of our training to deal with mood disorders. And I've actually used antipsychotic medications as well. Sometimes, of course, we work in conjunction with psychiatrists, but, patients with depression, anxiety come to primary care physicians first. So I would start with your primary care physician because we have that training. And many of my patients I'm treating for depression and anxiety myself, and I see significant improvements on medications. You might have heard of, medications like Prozac and so on. They're called serotonin uptake inhibitors, reuptake inhibitors, very commonly used by primary care physicians.
Thank you. This next question, I'm not sure their name, but it's iPhone. It says, my daughter has sleep apnea and doesn't get enough rest. Is it recommended that she use the CPAP machine during the day? She doesn't like to use it at night.
Dr. Totoyo, I can try to answer, but go ahead, Dr. Totoyo.
So many children do not like to have anything on their face. And we have at CHOC at least a team of psychologists who work on desensitization for using the CPAP. And they try to make it a fun activity to play, to try to get them used to use it during daytime. And then maybe they would be willing to accept it to put it on at nighttime. Or sometimes parents will wait for the child to fall asleep and then put the CPAP on. So there are different ways. So Dr. Dow, if you have any other tips.
Yes. And in fact, if you can, as Dr. Totoyo was saying, if you're able to get them to use it maybe during the day, just so that they get used to the machine. But it's when they're sleeping, things are floppy. Dr. Totoyo mentioned they're hypotonic. It means, things are floppy. So that when they're lying down and sleeping is when they need the machine, not when they're upright and during the day, for example. But if you can get them used to the idea of using it during the day and then use it at night when they're sleeping, I think that's probably a good idea.
Thank you. So our next question is from Alma. She says, my son had an ear, nose, and throat surgery when he was 4 years old due to his sleep apnea. And now that he's 12, she's noticing that he's snoring a lot. Should she worry about sleep apnea again?
Yes, definitely. And if tonsils adenoids were removed, the next step is to see a pulmonary doctor and do the sleep study again to see if indeed the child has sleep apnea, and then the pulmonary doctor will recommend the proper management.
Thank you, Dr. Totoyu. Alejandra's asking, can thyroid be under control without medication? She has a 5-year-old since birth that's been on medication, and the doctor has been put on hold, I believe.
So yes, thyroid can be under control without medication. So the doctors are looking at those lab tests, and depending on what those are showing, they determine if the patient needs to be or not on medication. I don't know, Dr. Dow, if you have any other
Sure. In fact, again, as Dr. Totoyo mentioned, it's by the lab result that we adjust medications, not so much the symptoms. People think, oh, I'm tired, people who are hypothyroid, oh, I'm tired, I feel like I'm cold all the time. Maybe we need to increase the medication dose. If the result is normal, we should not increase the medication, just going with the symptoms. So I'm sure your doctor is looking at the lab result and seeing that the result is normal. That's why the patient is off the medication. And so we have to go with lab results, not so much what the patients feel. And so some of the hypothyroid patients can be off medications because their thyroid is functioning okay. And then we probably need to check that thyroid function again in about a year or two.
Great, thank you. Carmen is asking, any tips for teeth grinding?
Teeth grinding usually happens in children. It's considered what we call a parasomnia, or a manifestation during sleep. I don't know about any medication that would control teeth grinding. You can speak with their dentist. Sometimes they can put some sealing material on the teeth to prevent erosion of the teeth. I know the sound may be disturbing, but also I would recommend maybe to do a sleep study to see if there is any other issue with their sleep.
Agree with Dr. Totoyo. Definitely work with the dentist. They may need a night guard, a mouth guard. Whether they are able to keep them in is another problem. But, definitely working with the dentist on that issue is what I would recommend as well.
Thank you so much. Bethany is asking, her daughter is about to turn 10 and she has gained 23 pounds since December. Her TSH, comprehensive metabolic panel, and CBC are normal. Her diet is well balanced, but it has been difficult to control her portion sizes. She swims daily and they see a nutritionist once a month. Any other suggestions you may have on how to decrease her weight?
Uh, I think the question or the answer probably is controlling the portion size. So you may set up the portion, and if they want seconds for the meal, try to provide food that it's low calorie, like carrot sticks, cucumbers, salads, things that have low calories and tend to um, help fill up that need for more food. And also try to engage them in like daily activities, maybe increase the time that they do activities.
I think the type of activity, because I believe since swimming is anaerobic, not aerobic exercise, I don't know if it's as effective in helping weight loss as some other type of aerobic exercise. But also she may be eating, if she's snacking, eating out of boredom too. So by having her engage in something else, that might also take her mind off food.
Yeah, I definitely agree with both Doctors Hom and Totoyo. I heard diet, but I didn't hear about exercise. I mean, I think if we can incorporate exercise that the individual enjoys, like dancing, for example, Zumba, for example, an hour every day, some sort of really structured exercise is what I would recommend to that balanced diet.
Yeah, you don't even have to take them to a studio. There's plenty of things you can find on the internet and where they can just have a dance class or party at home.
Great, thank you. This person doesn't have a name. It's iPhone 233 on the chat, but they said their daughter, who is 22 years old, has recently stating she's been feeling dizzy. Do you have any idea what that could be or any possibilities?
Please talk to your primary care physician. Dizziness has many what we would call, differential diagnosis. So it needs a workup. Dizziness needs a workup. It could be vertigo, where it's a spinning sensation versus lightheadedness. It could be a lack of balance. So you need to start with a primary care physician.
Agree.
Thank you. Okay, Melissa said, to add to what Melanie was saying about regression syndrome, as the caregiver, I would like to know, what does refusal look like to you? The child will be in the middle of walking to a task and then look very lost in the process of completing the task. So as the adult, you just repeat the task and then the child will continue only to glitch in a way and look lost in the process of completing again. In my experience, refusing looks different to me. What, in your opinion, should we look for?
Yes, that's not what she's describing does not sound like refusal. Refusal is when someone obviously outright says no. Some people with Down syndrome drop to the ground. Some just figuratively dig in their heels. Or they may be defiant and actually do the opposite of what they were asked to do. So if they were asked to clean up and put their toys away to get ready for dinner, they may continue purposely playing with their toys or on the iPad and refuse to give that up. This getting lost or confused in the middle of doing something, if this is new, this is something that I would, again, go to the primary care physician first. It could be, there's also similar to that dizziness, there could be different causes for either this delirium or confusion.
If I recall, this patient may be 15-year-old, right? You have to think also about absence seizures, because this description looks like the child is doing an activity and suddenly stops, lost for some time, and then they will continue the activity. So I would think that this child would need also an EEG to make sure that they rule out seizures.
Great, thank you. Alma's now asking, what does a sleep study for kids look like?
So They are requested to come to the diagnostic lab usually around 7 p.m. The technologist will place some leads on the head. They look similar to the EKG leads because I believe everyone is aware of how they do the heart EKG when they put those little stickers on the chest. The same way they apply some stickers on the head. It's not tape like on the skin, but they attach it with like a paste. It looks like the toothpaste. They comb the hair, make some clean areas, and attach those little electrodes. They wrap the head with the gauze, and then the child will sleep in the bed with their parent overnight, and they record the way they breathe. I believe also for the adults, they will allow a parent or a companion to be there with them. In the morning, they disconnect those leads, and then a sleep doctor will read the study, and then they will let you know what the result is. Sometimes, at least at our hospital, it may take up to 2 weeks to get the result because it's a lot of information that they have to look through.
Thank you. Peter and Ross is asking, is high pain threshold common in Down syndrome? My 31-year-old son has limited verbal communication. I would only notice if he does facial grimacing. Is autism and OCD common in Down syndrome?
I'll take the question about the pain threshold. That is something that I notice all the time. And people who are not able to express pain is definitely a challenge. But many of my parents and caregivers say they do not express pain. And so that is probably something that we have observed. They don't express pain much. Sometimes they show you an area and say, oh, and are you having pain? And they may, yes, but they may say yes to everything, especially those with limited verbal proficiency. But yes, that is definitely something that I have observed.
I observed the same thing in children as well as in the adults that we see in the research studies, that they can have a very high pain threshold, and they are not complainers as well. So you have to really look for their facial expression and other signs that will guide you to see that they are in pain. And yes, autism is more common in children with Down syndrome. They can have probably 15% of children with Down syndrome have co-occurring autism. And OCD is also common in the sense that they like very much routine. They are very structured. They like to organize their belongings. Many of the adults that we see in the research studies at their own home, their closets are very organized. All their clothes are very neatly folded. Everything is like very well organized. You may call this OCD, but they like very much routine.
Yeah, so technically OCD is an anxiety disorder. And so it's usually behaviors that are done repetitively due to anxiety. So there's sort of a mislabeling, but in Down syndrome, it tends to be more repetitive behaviors and repetitive activities that they enjoy. It is not as a way to ward off or counter some sort of anxiety, such as, fear of contamination and getting sick. But it is common for people with Down syndrome to like and have that routine.
So for me, I would say OCD, the disorder is more of a interferes with daily function because of the need to do that same routine over and over. But by and large, most Down syndrome individuals like a strict routine, as everyone mentioned. But OCD is when it really interferes with their daily function.
Thank you. Abigail asks, my son had the tonsils and adenoid glands removed because of sleep apnea. It improves for a few years. He had another sleep study last year and he still has sleep apnea. He still needs to wear a CPAP, but he doesn't like it. Any thoughts?
As said before, I think it's important to maybe try to work with a child life specialist or as a counselor or psychologist to try to get them accustomed to wearing the CPAP during daytime, and maybe after that can transition to accept it at nighttime when they sleep. But yes, it's important to wear the CPAP and to manage the sleep apnea, because there are studies showing that if a patient has sleep apnea, they might lose quite a high number of IQ points. So it's important to do whatever it takes to get them used to wear the CPAP if it's needed. And now I think that there is also research ongoing for some devices that looks like a pacer that they implant on the tongue nerves to try to help sleep apnea. Our hospital, I think, also already started using it. It's called Inspire. I don't know exactly what the criteria they need to meet to have that implanted, but I was told that it's working.
Lots of times insurance doesn't cover that. There's a
Mhm.
index, a number that they have to meet in order for
Yeah.
them to
Mhm.
be candidates for Inspire. Yeah, insurance is another issue.
Yeah.
There is a study for children with Down syndrome out of Colorado Children's Hospital for, I don't know if it's that exact same implant, but some sort of implant device. And so if you're part of that research study, the research grant covers the costs associated with
Mm.
that.
Thank you. And I believe Melanie is asking, we've done several EEGs and saw a neurology evaluation. It all remains indeterminate. She gets hand tremors while writing. We had her on Keppra and didn't seem to change, and they're asking for some help and suggestions. This will be our last question for today. We've hit the 11:30 mark, so.
Thank you.
I may suggest maybe try to see a second opinion for neurologist. I don't know if the patient had already maybe imaging studies, MRI, to look for those causes for the tremors. People with Down syndrome can have also essential tremor or exaggerated physiological tremor. So there are many different things that it could be. It's hard to give advice without effectively seeing a patient. But yes, that would be my suggestion. Maybe ask for a second opinion.
Thank you so much, Dr. Chitoyu. We're going to move on to a next slide. So this is a bit of promotion. So here at UCI, we have our annual Down syndrome showcase. This year will be our second annual. So we are inviting everyone to come out and join us and support the community of children and adults with Down syndrome that will be showcasing their wonderful talents. It will be on September 29th from 2 to 5, but the exhibit will be opening, or doors will be opening at 1:30. And this is going to be at the Irvine Barclay Theater in Irvine, California. Also, if you have a loved one with Down syndrome who would be interested in performing or showcasing their art that day, please contact Kelly. She's one of our other coordinators here at our studies at UCI. And our last date to register is August 1st. Tickets are also available at the Barclay website, which is right here on the link at the bottom. And yeah, other than that, I believe that is it for today. We hope you found this presentation very useful. And if you would like a copy of these slides, please contact the email below.
Okay, that's
Thank you
nice.
so
You can
much.
show me a little bit.
Thank you.
Thank you for spending your morning here. We really appreciate it. Thank you for everyone else to join us. And that's a beautiful photo that I see now on your screen. And I believe that we're gonna have the slides available. I can forward that when I receive them. Thank you so much for, our three doctors here this morning, spending your morning, and hopefully it's not the last time we're going to see you here. I think that we still have a lot of follow-up questions, but we really appreciate your time. And I also wanted to remind you that we're having our walk November 3rd. We're all invited to come and celebrate our loved ones with Down syndrome. Please check out our website. It's dsala.org. We have, a list of programs and other presentations that we have lined up for you. Thank you so much and have a wonderful weekend. And I really appreciate you. I think Melanie wanted to, I'm sorry, I cut you off in the middle of something, but thank you so much and have a wonderful weekend. Bye. Thank you. Bye-bye. Bye.